We have the last session of the day. So while I still have everyone's attention, the majority of people are in the room. Just a reminder, tomorrow we meet at 8:15 at the exact same spot that we met today. So 8:15, and then it's basically a copy and paste in terms of time from today. So that's the first thing. The second thing is that we will be in CVC 217. So it's not in this room, but on the other side of this building. I'm not going to confuse you anymore. Just meet outside tomorrow, and we're going to be walking it at 8:15. So everyone, please be on time. All right. So session 9, addressing the challenges of clinical workforce shortages, exploring innovative staffing models. We are pleased to have with us Brian Arkwright. He is a principal at Impact Advisors and founder and chief research officer at Cromford Health. He's an adjunct faculty professor at Wake Forest University and Ohio University. Go Buckeyes. Jasmine Bishop is with us today. She's the managing director at MedStar Telehealth Innovation Center. And then Dr. Lisa May Williams. She's the chief nursing officer at Intercept Telehealth, and she is also a consultant at Blue Cirrus Consulting. We are honored to have you all here with us today. As a reminder, we do have a tabletop question. So we're going to give each of the panelists an opportunity to give a short presentation, and then we're going to throw the tabletop question out to you. And that question is listed in red at the top. What obstacles do organizations encounter when striving to maintain adequate staffing amidst the current shortages? And I'm going to hand it over to Lisa.
Okay. So because we're between you all and happy hour, well, let's get started, right? I just wanted to point out that Molly, I'm right there with you as a nurse. We're very judgmental, to be honest. And I know we had that same discussion about what a coach is really, and because we were taught in nursing school that we were coaches, so go figure. So this topic is very interesting, and it's really quite serious at the same time. We know that on the whole landscape after the pandemic, what we experienced, and after the pandemic, what is continuing, is really fundamentally a sea change in how we're staffing, especially on the acute care side in the hospitals. And as a nurse, I'm speaking from the nursing perspective, how difficult hospitals are finding it to provide the appropriate staffing to take care of the high acuity patients that we have. The American Association of Critical Care Nurses in 2021 did a survey of nurses and looking at their perception of the work environment. And the numbers were very, very stark. One data point in particular was looking at the number of nurses that were intending to leave the profession within the next year, 67%. That is not sustainable. So we have to do something about it. And hospitals, and I show of hands, how many of you, this is a hot topic for you all in providing appropriate staffing, especially when it comes to nursing. And so just a couple of points that I wanted for us to think about. First is looking at the landscape post-pandemic, but looking at the synergy between our level of acuity of our patients and the characteristics or the competencies of the nurses and matching that. So we've had a high turnover of our expert and experienced nurses. We lost a lot of them from the profession, but we also lost a lot of them from working at one facility to moving on and doing travel nursing or registered nursing or whatever you call it. And so we have a decrease in the number of expert nurses that are staying in the hospitals and making this a long-term career. And we're seeing that with our intensivists and our physicians and our nurse practitioners too. We used to have staff that were loyal to the organization and they stayed for long periods of time. That's what they wanted to do, but we're finding that there are a lot of exit ramps. And people are now looking for work-life harmonization where they can have a hybrid life, where they can work a few days in the hospital and another few days remotely. So what are we as organizations doing to fill the gap between what we're seeing in the hospital and what the patients need and what expertise are available? And so we have been thinking about this topic in our organizations, and a lot of folks are moving towards virtual nursing as a way to fill that gap. And we are going to have a webinar in a couple of weeks talking about this, because you might have those resources that are within your hospital that you can leverage to sustain not just the volume of the nurses, but the quality of the nurses and the expertise. And by doing that virtual nursing model, taking tasks off of the on-site nurses' plate, but also providing them with resource expertise. We have a shortage of educators, for example, or coaches for us, right? Educators, where we're now providing e-coaching to the nurses, because as they're coming out of the universities, they're not as equipped in the clinical realm as they once were. So there's a lot of on-the-job training that's going on. And we're discussing earlier that are the universities preparing our students and our nurses and our coming out to meet the needs that in this new world. So I am going to hand it over to to Jessa, so that she can talk a little bit about how we can use AI, like predictive staffing models, for example, and also what other options are out there for us to be able to address this nursing, not only nursing, but general staff shortage that we have, because it's here to stay, and we have to become flexible in our thinking as healthcare providers in how we deliver the care, and even in the acute space, that nurses don't always have to be physically in the hospital, nor do our providers. So we have to figure that out. So let's have that conversation, and then we'll circle back. Yeah.
All right. Thank you, Lisa May. Appreciate you kicking us off. So my name's Jasmine Bishop. I'm our managing director, as was previously described to you by Krista. She did not lie to you, at MedStar Health. We are right here. So MedStar Health is right where you're sitting. Me and my 3 colleagues who joined you today had to walk about a mile to get here. And I appreciate all of you that came from much further. These conversations, before I dive into some of what MedStar is doing in this topic, is I love these smaller group interactions, because we not only had the opportunity to talk about the panels today and some of the table talk, but I'm sure just like we've experienced around our table, you've all made new connections as well that are going to be enduring beyond this week. And so really a big shout out to CTeL for creating that opportunity for us. Specific to clinical workforce shortages, this is about 70% of my week each week these days. And it's because we have 2,000 or so nursing vacancies right now across our 10 hospital health system. We're here in DC, we're in Maryland, and we have an ambulatory footprint in Virginia. But our hospitals are centered 2 here in DC, including Georgetown, and 3 here in DC and 7 in Maryland. When I think about how we address the challenges, I think the number one thing is being cohesive across our health system. If our nursing leaders and our HR teams went to solve the staffing shortage in one corner of the health system, we wouldn't be where we are today with the solution. It's the opportunity for us to connect with my team, who sits under our Innovation Institute, alongside nursing leadership, alongside our medical group, to think differently about solving some of these challenges. So if I stick to the inpatient space for a second, when we think about all of the cool tech that we can bring to our hospitals, we have an amazing program where we're leveraging the televisions that are in the patient's room to virtualize the whiteboard, to provide a clean space for all that clinical information. That's really cool on its own. We also have an opportunity to swap out what is one-to-one sitting for fall risks and switch that to what is more traditionally called telesitting. We call it remote visual monitoring. That's also really cool. If we did those things in silos, though, we'd end up with like 5 new audio and video devices in each patient room, and there'd be no space for the family to stand. I know my granny was just in this experience using a remote visual monitoring mobile cart. Those things have a huge footprint. You trip on them, and it's important because you don't want them to knock over, right? But we need to think differently, not only about the staffing side, but how we pair the tech with resolving some of the staffing shortages. So specifically at MedStar, what we're looking at is how do we leverage that television not only to do cool things like virtualizing the whiteboard, but also put a camera on top of that screen to be able to have our sitters continuously watch those patients that are fall risk, have virtual nurses take over that camera feed when they need to support our nursing teams with not just admission and discharge, that's awesome, but also that patient education in between. Also that coaching that was described as well, the newer nurses that are at the patient's bedside, how can a more experienced virtual nurse be able to coach them? And a lot of times we're looking at this as a retention strategy for those nurses that have been in practice for 30 years and 12-hour shifts on their feet, really not an option anymore. And so how do we leverage all that great expertise in a new way that allows for our new nurses to benefit from their expertise and then also retain those nurses that might stay 5 or even 10 years longer if they have this option? I think as we think about table talk discussions, if others are thinking about this model, again, it's about not just doing one thing at a time, virtual nursing, telesitting, inpatient technology transformation, pairing all of that with the nursing shortage. There's some big questions, though. There's equity questions, right? There's nurses that are on the floors that are saying, hey, I want to go sit at home or down the hall in a command center staring at a screen. That sounds pretty good. How do we think differently about the scheduling? How do we say, okay, you get 2 shifts a week, and then you still have the same knowledge about how that unit does their work too, and it's Amy or it's John that I know, and I'm trusting them to take over the care of the patient. So that's something to think about when we think about the virtual nursing side. When we talk about workforce shortages in our global model of care, we think differently about who's physically going to that patient's bedside. It doesn't always need to be a nurse. We can expand the care team, address that nursing shortage by leveraging LPNs or PCTs in a different way. Well, this ties back to telesitting because a lot of our PCTs are being used to be our sitters. So how do we resolve that problem? We bring in telesitters that instead of a one-to-one sitting relationship, we have 12 patients being monitored by a single sitter. There's technology that can go up to 18 or 24. There's a big question there, quality and safety. Now this ties us to AI. How do we teach the software to tell the real human that's in the loop there which box, which Brady Bunch square to pay attention to, because the patient's arm is moving in such a way that our large language model understands is synonymous with the patient that's about to fall out of bed, and then automatically trigger an alert that sounds an alarm in the patient's room without even the sitter's involvement, so bedside care teams can run in and resolve the issue. So that's where we can talk about nursing shortage, leveraging cool tech that teams like mine are excited about, but also doing it in a way that's forward-looking and future-proofed so that we can make good use of AI as it comes to be available to us, and then do so in concert with our entire leadership across our health system, in concert with our IS teams, in concert with our leadership, our clinical leadership, as well as our operational leadership. So that's one model that we have. I think that there's probably people in this room that don't do hospital care. So thinking about the ambulatory space, just moving quickly into another workforce shortage opportunity. So a few years ago, before my time at MedStar, so I'll just parrot a story of success from my team, there was an acknowledgement that our primary care teams were not adequately being able to, as one pain point, respond to all the portal messages that are coming in from patients, right? This is a classic challenge that we have across all sites of care that have EMRs, which is almost all of them since 2015. The answer was pajama time. The answer was finishing your day of patients and then spending 3 hours at night answering all of those messages. And there's an equity issue because your patient panel is varied, and this provider A might not get as many messages as provider B. And there's been plenty of studies that correlate these messaging to provider burnout. So now we're bringing in the well-being aspect as well as the technical, the operational, and the clinical. So when we think about this, it's not necessarily a human shortage so much as it is thinking differently about the work that we do and working at the top of our experience. The model that the team employed is leveraging what we call our connected care model. So we have a connected care team that is a virtual team of an NP and an MA that is set to support 4 or 5 primary care practices in what we call pods. This team will support the portal messaging, they'll support doing prescription refills, and they'll even do same-day, next-day telehealth visits to increase access. So because this was not my program, I do not have the stats off the top of my head, so I do have a piece of paper. So this has worked phenomenally well. We're really excited that it's worked so well that now we're trying it in our specialty practices, first with cardiology and next with diabetes. But in the connected primary care space, some of the high-level stats, we had over 14,000 telehealth visits that this team supported, 52% improvement in hypertension. Well, where did that come from? Part of the model was RPM. So part of the model was giving devices to patients and having that virtual team actually do the monitoring and only alerting the PCP when absolutely necessary. 42% in next available appointment. 24th percentile improvement in TalkBox Press Ganey patient experience scores. So this is starting to impact that patient experience. So well-being, technical efficiency, clinical, and now we're talking about patient experience. And then lastly, back to that pajama time, we had a 35% decrease in after-hours EHR time. Our EHR, we were able to look at what's called lights-on data to be able to see how much our providers are logged in. We saw a 35% decrease in that time. And then they filled 220,000 prescriptions. That's pretty important. That's impactful to those primary care teams. And part of our Innovation Institute includes a Center for Wellbeing. So that's back to the connectiveness around the system. When we employ an idea like this, we're not just thinking about how it can help the bottom line, which is important, no margin, no mission. But it's also about making sure that we connect back to the well-being aspect. How do we impact the retention rates? How do we impact hiring? And most importantly, how do we impact our clinical care and our patient experience? So those are just 2 models that we've described. Hopefully one resonates or the other if you're inpatient or you're ambulatory. I'll bring up one last because it is important that we talk about the truth of what automation is and what AI can bring. One provider, I think it was Dr. Tom, said his profession is probably safe for some time, right? There's a truth that AI is going to, taking jobs sounds so negative, reframe how we do work. It might be political speech there, but it's about reframing how we do work. And I do have one example of that, which is we leverage what we call patient engagement solutions. It's really just digitizing the way we connect with patients through SMS and email to resolve a challenge that we had in our pre-anesthesia testing space. These are patients scheduled for surgery. They need anesthesia clearance. Our former model had nurses calling patients ad hoc. 45% of the time they weren't answering the phone. And then I'm sure the rest of the time when they did, they weren't super excited that they were then on the phone for 30 to 45 minutes being walked through an anesthesia clearance form. So in this model, we were able to save the health system $2 million a year by employing a patient engagement solution, digitizing that form. 72% of the time, our patients are successfully filling out a 75-question survey about their care. That savings came from 22 FTEs being reallocated in our system. Like, that is the right way to be using our nurses to reallocate towards nursing positions. But it is a truth about how some of these cost savings are realized and how AI automation, and in this case, it's not true AI, it's algorithmic patient engagement where it's no natural language processing. It's not a conversational AI. We're saying if the patient says this, then say this, but we have to type in every response. That's not true AI, right? That's just, I mean, anyone that's built a SurveyMonkey tool has done this, right? Although my team hates when I suggest that it's that easy. That's my perspective. So those are 3 different areas, 2 that are wholly positive that we're leveraging tech plus operational efficiencies to address the workforce shortage. But then hopefully it brings up some other thoughts about how does AI impact shortages in a way that might change the way people do work. All right, Brian.
Yeah, I'll just pick up where she left off, and great job, Lisa and Jasmine. You know, with the, let's see, I'll be right here. Let's do that. With kind of a short story, I'll grab cohesiveness and retention and share a story. We've been through Impact Advisors, we've been working with the health system up in Chicago, a fairly large one, and this is more on the ambulatory side. But we've been working with them and really charted out what we call call center automation. They had a lot of challenges from patient experience of the patients calling in and really feeling like they had a great experience, a cohesive experience, and that who they were talking to, which included both non-clinical and clinical staff, and really, as those calls came in, the direction of where those calls go, really feeling like whoever they were talking to, first or second, or in some cases third, that individual really had a sense of who they were talking to, and that you know, when you call into a call center, that everybody's working for you and that they're working together for you as the patient. And in some cases, the referring physician, outside provider groups calling in. You know, this organization had several call centers across 9 facilities, and we started with some of the largest ones that handle both non-clinical and clinical. And part of that was reworking some decision trees that often suggested when they might need or be a right fit for a video visit, virtual visit. So that was one quick thing that helped kind of alleviate some of the staffing on there was over 300 ambulatory clinics that they operated, and it was a kind of a design of some centralized call centers and some decentralized call centers. So we really targeted our effort a lot in the centralized. There were 4 major software systems that we used. One was IVR, or interactive voice response, shifting from the traditional press 1 for this, press 2 for these different options, allowing the patient to actually say where they wanted to direct their call. So a lot of automation right out of the gate. That software alone reduced calls by 50%. And from the get-go, as we implemented that technology further throughout the system, we started to see a reduction in labor over the past year. And even, you know, implementing this technology, I haven't implemented the voice in the past, and you know, the vendor did tout the use of artificial intelligence. And so having kind of not used that specific technology, we didn't really project a lot of savings. But that program's been, the IVR system's been in for over 14 months, and we have seen a range of $129,000 all the way up to $205,000 savings consistently month after month. Since that saving, and everybody's been blown away by that. A big reason is those call centers were using significant outsourced support, so both clinical and non-clinical staff that they had to go out to an outside provider, and you're paying top dollar for those. They were using lots of overtime, and they struggled with really matching the alignment of calls, call volume, and they were using some antiquated, you know, touch tone options. So shifting to that voice, utilizing that AI, we've consistently, and we're still seeing that range in the 6 figures each month. So very excited about that. They've right-sized. Within the 3rd month, they stopped using all outsourced staff. So that was the big savings right out of the gate. Then they stopped using all overtime pretty quickly too. So they have a much happier staff. The retention's gone down. They're not using that outsource, which also, usually led to more customer service type issues or patient complaints from time to time. Simultaneous to the IVR, there were 3 additional, that was, I would say, the big labor savings that we saw. We also implemented a workforce management software, an automated quality recording, which is call recording. You have to do a lot of call recording in these call centers. And then lastly, we did a CRM system. And they chose, what is customer relationship management. They chose CTeL, which is an Epic product, and they're an Epic shop. And through those 3 systems, I'll kind of start quickly with the workforce management. They started to have estimates, and really the AI helped the managers to really match that call volume to their staffing. So again, helping with, you took the IVR, you kind of built on that, you added the workforce management. Your managers now had a tool to say, look, for like 4:55, we usually send people home, but let's start staffing till 7, because that's when we hit a spike in calls. So they've been able to adjust those staffing because of those AI recommendations. And of course, the average response rate and the average wait time, handle time, all of that has gone in the right direction. And they were doing pretty well already with some of those key metrics. Lastly, I'll mention the call recording was a previously archaic system. It was really just complaint driven. A complaint would come in from a patient. A manager would have to see who were they talking to, was it clinical, non-clinical, and then go look up the recording, listen to the recording, and then figure out their action. In the new system, the automated call recording, the manager can quickly look at a dashboard live, or they can kind of look at the end of the day. They do a little bit of both, and they see certain things like S. S means there was a long silence on the phone, and they can see exactly when that was, what patient they were talking to, and that's not good customer service. So that might have been there was an issue. Maybe they left that person on hold too long, and you can immediately talk to that agent at the end of the day, see what happened, see if there was any issues, and an opportunity to improve that. The other thing is it's C for crosstalk, and that will tell you if there was some crosstalk going on. Again, another opportunity to investigate that call, see hey agent, like what happened, not necessarily coming at them in a punitive way, but really just an investigative way and an engaged manager way to work with that agent to see what happened. And again, this is both non-clinical and clinical folks that it's being utilized with. And then the last one is an R that the AI suggests, and that's where somebody raised their voice. So you can, whether it was a patient and there are times, if you've done anything with telecom, and we're all in virtual care, so you may have experienced this in virtual care where patients sometimes have to be terminated from a system. They've been patient's gone wild situation, you got to get rid of them. That technology, that can be, very helpful to immediately find the recording of that conversation, get the agent's debrief of it, even play back if you need to that patient, or for additional reasoning, or maybe you're working with the general counsel's office as to what proof you have as to why that patient was terminated. So that's another example. And then lastly, with the CRM CTeL, really just we've seen amazing stuff in terms of, I've talked through the labor savings. Where we've seen the CTeL start to work really great is, the system had an issue with really unfulfilled orders. So you'd have specialist orders from the primary care office, from the ER, from the inpatient stays, whether it was to see a specialist, to get a lab, or to have imaging done. A lot of those were falling through the cracks, really too many. And the CRM CTeL system allowed these clinical and non-clinical agents to take a call. No matter where the call came in, they could see what agent worked on it, what they did, and what outstanding orders there were, and also outstanding balance for any revenue folks. So they could start to see, what systems those were, what where were they falling through the cracks. Maybe you can see if they showed up to, the wrong location, and really start to match and help them fulfill that order. And often that order, we put some very conservative estimates of the revenue and began tracking the value. And we're starting to see, we had over $150,000 in our first month of new revenue generated. And then we just added a significant more agents live on the system. And we're now at close to $500,000 in new revenue generation using the Cheers. I really, put it to the next best action, which is what Epic is using with Microsoft's Copilot and some of their uses of Gen AI and AI in their new system. So taking those next best actions, which really is identifying if they have an order, an unfilled order, and then being able to fill it. Just some few examples of that really automation and retention, and the agents love it. Call center agents, call centers can be tricky to work with. There's high turnover, there's low staff satisfaction, and we've heard from the clinical agents and the non-clinical agents of how effective the tools are, and that they can present themselves on the phone and truly give the patients a sense of, I'm here from you and I'm working with everybody behind me at my health system to ensure that you have the best possible care, the best possible experience while you're on the phone with me. And I think that those next best actions are kind of a key piece of that. So I'll wrap there. I think we're going to go to the tables with some discussion. Right? Or do we want to come back? You want to say something? You can say something. Okay, table it. We have some questions listed there. I think we can, I would look at the questions, but also ask us questions. Look at those questions, answer them, and then we just love some, interesting round table discussions.
Looks like we're having some really good discussions at the tables. Hello. All right, let's circle back, guys, as I said. So we've just to wrap up here, and then we're going to hear from a couple of the tables as far as what you all see as the solution. You were solving world hunger, right? So you all, since you're still having the conversations, you all have cured the staffing shortage. I'm sure of it. So earlier, I forgot the speaker's name. He used this little, guys, can I have your attention, please? The speaker earlier, I apologize, I don't remember his name, but he uses really, I think, very catchy way of synthesizing information. The what, so what, now what? All right, you remembered, awesome. So what's the issue, right? The issue is that we have a clinical workforce shortage, right? Okay, so that's the what, and we have to provide some sort of synergy between what we have and what we need to have, right? We have to fill that gap. So the so what, that patients need to be cared for by the highest level of experts available, and we need to be able to leverage technology, AI, and all of our tools to be able to meet those goals. So now what? We need to continue developing our AI strategies to help us to facilitate these goals that we're looking for. Did I do a good job? All right. So who has a what? So what, now what? I want to hear from you guys, from the tables, from your discussion. All right, don't all raise your hands at once. Remember, you're solving the clinical workforce shortage. Come on now. All right, okay, you need the microphone? Here you go. All right, please.
Thank you. I'm Kushid Zbar from UCLA Health. What is actually, there was an issue, a situation where in our OB departments when the patients go in for delivery, they had to complete this Edinburgh questionnaire. It's a very specific questionnaire, which they have to, it is law. they have to do it twice, once when they're admitted and once the patient delivers. So previously, it was a paper that a nurse had to go take time and chase after the patient when they're admitted and then complete that. And again, the second time they have to do it after they deliver. So what we did was we automated and created a questionnaire. We are an Epic facility, so we have bedside, which is deployed on, we have like 1,000 iPads deployed at each room. So it's available on their iPads in bedside to complete the questionnaires, and they are alerted, but even the nurses go tell the patients like, oh yeah, you have this questionnaire, complete that when you have time. And we have seen that it saves time on the nurse's side, and also the patients are more willing to complete these questions and privacy because there's nobody standing on their head asking these questions. We found great patient satisfaction, and also the nursing staff is so happy with it because I think 85% of the time these questionnaires are completed. So, and also we also do another thing. We have an AI-generated message for physicians. The physicians have to answer the patient messages, so we do generate the answer, like the reply to that message by AI, but the physician has ability to edit the message before they send out. So that saves some time for the physician. So it helps with physician burnout. That's what I was talking to here. Thanks.
Great job.
Thank you so much. Anybody else? What? So what? Now what? I see Molly, you're pointing, or you're raising your arm. Okay, there we go.
Alrighty. So the what was there after really the great resignation, of staff that happened in 2021 or so. The nursing staff at one of our northern market hospitals had a high number of seasoned or hour nurses resign. So that's kind of the what. So what? So then a hiring happened of nurses, nursing staff, but most of them were under 27 hours, 28 hours on the floor experience. So they were lacking a gap of experience and knowledge. So now what? What we developed was a virtual nursing program for 2 FTEs were hired for the position. So the great thing about it is leadership in that space and area came and said, this is what we'd like to do. We know we have this gap. We know we have virtual care. Can we fill the gap with that? So it's ran for about 9 months or so. The nurse is available during the night hours for those nurses on staff to answer questions. Maybe it's medication, care instructions, whatever those are. The second phase of it will be those nurses being able to see patients at bedside. And so that'll be the second expansion of it, which is unbelievable that it's worked so well. But it has.
Your virtual nurses were the experienced ones. You brought them back in.
Yes, so the virtual nurses are the experienced ones that saw nurses on staff with a lower experience level.
Yeah, that's the e-coaching.
Thank you. And
Oh, yeah,
Yes.
that's good.
Do we have any other questions for the panel? All right. Well, we encourage all of you to network amongst yourselves. There's some really great pubs around here and places to go get dinner. So please, find a friend and find a friend. But this concludes the first day of our presentation and our panels, and we're very appreciative of everyone, and we are very appreciative of this panel. And then we will see you tomorrow. Remember, entry is at 8:15, so please be at the doors no later than 8 a.m.